Hello, good afternoon.
Good afternoon, Nico. How are you?
Can you hear me?
Yes, we can hear you.
Oh, fantastic.
Good afternoon.
Good afternoon.
It is a pleasure to participate in this wonderful event. First of all, I would like to thank the organizers for, making this happening. I know it's difficult in these times.
Yes, absolutely. So thank you very much for joining this small atelier on COVID innovation. We do live in very difficult times, and we are very honored to have some distinguished speakers today. We will be hearing from Professor Peter Ianakiev of Hera Biosciences. So thank you for joining. Professor Osman Ugur Sezerman, who I think has not joined our panel yet, and Professor Alexander Lezhava.
Yeah.
Sandro, welcome to this.
Thank you very much.
And Ugur Sezerman has just joined us. Hello? Can you hear us? Okay, maybe we'll get to the introduction. I will let each panelist introduce themselves, and then we will start with the short presentations. Just as an introduction, so my name is Dr. Nico Forraz. I'm CEO of CTI-Biotech in Lyon, France. CTI-Biotech specializes in personalized medicine solutions to create human tissue models in 3D to facilitate drug discovery and dermocosmetics applications. Today, the topic of our atelier is on COVID-19 innovation, mostly in terms of precision medicine and diagnostics. We've got some very exciting contributions. We are about 32 million cases around the world with COVID-19, the coronavirus, close to 1 million deaths that can be somewhat related to this pandemic event. And you will hear some interesting technology and initiatives through different countries this afternoon. If I may start with Sandro, Dr. Alexander Lezhava, an associate director at the Genome Institute of Singapore. Professor Lezhava, if you could please introduce yourself and the topic of your...
Yeah, I'm Alexander or Sandro Lezhava, and I work at the Genome Institute of Singapore as a head of Translational Research Lab and also head of Clinical Lab. So yeah, I'm directly involved in, so my specialization is molecular diagnostics, and I'm directly involved in the lab testing right now because we build the lab here in our institute, and also I'm developing assays as well. Yeah, thank you.
Thank you. I don't know if Professor Ugur Sezerman is on the line. I can see his name, but I'm not sure he's connected.
Can you hear me? No.
Yes. Hello, Ugur.
Okay.
Welcome.
Somehow
Welcome to
the
the panel.
video is not working. This is Ugur Sezerman. I'm a professor of bioinformatics at Acibadem School of Medicine. I also do biotechnological applications for sequencing and other types of projects. And we have done several sequencing for COVID-19. And then we developed a diagnostic kit using the LAMP-based technologies, which I will discuss later. But I'm also involved in several COVID projects, international projects, for sequencing of hospitals and sewage water systems. I will also briefly describe those activities as well. And it's nice to be part of this panel.
Thank you, Professor Sezerman, for your introduction. And last but not least, I will ask Professor Peter Ianakiev to introduce himself.
Thank you very much. My name is Peter Ianakiev. I am currently owner of Hera Biosciences. Hera started about 4 years ago with the premise that we can help small and intermediate sized companies with their technologies in the field of next generation sequencing, so they can utilize this powerful technology for their own needs. We have been working in the field of renewable energy, novel plastics that are biodegradable, and as well as personalized medicine to some extent. Currently, Hera Biosciences is back into stealth mode because we are developing something very, very interesting in the field of information and DNA as a carrier of informational storage.
Thank you very much for your introduction. Professor Lezhava, you had some slides to show us. Sandro?
I don't have slides, but I can give updates from my side.
Okay.
Basically, in Singapore, I can say that we are handling quite well. So immediately when pandemic started, so government took a number of actions. So we had and started immediately monitoring and isolating those cases. And that was worked quite successfully. However, at some point, the infection went to dormitories, and that was a very big spike. And daily we already have, before we had 20 and those numbers, but it jumped up to 1,000 and so on, because those dormitories are quite dense, and there are thousands of workers are living there. But however, again, government took kind of precautions. They introduced restrictions and isolated the population which were under the risk, and also quarantined them. And finally, I think those cases are dropping now, and we have already quite good numbers back, let's say, if we can say so. And we have, let's say, yesterday was 15 cases, and only out of 15, 5 cases was reported. So we can say that, and also on the same time, also the restrictions are lifting. Now more people are coming back to work. Before we had very strict kind of who can stay home, they stayed home, coming back. We have also a good sign that the restrictions are lifted for children up to 6. They don't need to wear masks. However, masks are quite obligatory, and we have to use all those masks. Always have to be covered in public places, outside, and so on. Besides those precautions, besides those measures was being taken, of course, the other like diagnostics plays very big role in disease monitoring, and also to stop one or another spread. And in that case, also we had quite. I think Singapore is daily if I'm currently not mistaken, is running about 40,000 tests a day around there, or the aiming that. And those testing facilities are in most of hospitals, and all at the same time, private companies are involved as well. And we, as a Genome Institute, we also took some kind of active part there, and we, upon Ministry of Health's kind of recommendations and discussion with them, so we decided to build a lab inside of the institute, and this was quite, and that was done in a very quite rapid manner. In 1 month's time, plus, let's say 1 month plus time, we could manage to introduce the test and build the infrastructure, and also validate this test, and also get full life of this with a PCR test. So currently we've been doing 1,000 tests, and then per day, and then we build another facility, and we are aiming to go up to 10,000 a day. This is only, again, our organization is contributing, but behind that was, of course, there was a very huge efforts, sleepless nights but the society was quite consolidated, our scientific society, or many volunteers we had, and they came, and they showed their will to participate in this important kind of action, which was done for Singapore. So, and we were all of us, we were on the same page, and I think we are running that quite successfully. On the same time, I am assay developer as well. I developed 2 assays, was PCR assay and also isothermal amplification assay. I think my colleague has some slides. I think that is, I don't say that we have anything particularly original, but yeah, but there was a need, and we came up with those assays. Yeah. Most important in this case was efficiency and also timing. So that's what I can add on my side. Thank you. And later, I think I will take part in discussions and answer questions as well. Thank you very much.
Thank you very much, Professor Lezhava, for your contribution. I know that Professor Sezerman cannot stay for the entire time here because he's part of a national panel on COVID-19 diagnostics. Professor Sezerman, could you tell us a little bit about your work over in Turkey and your international collaborations?
Okay, actually I had sent a small presentation about what we are doing here in Turkey. I think we are starting. Yeah. So what we do here is we are part of a consortium called MetaSub, and its aim is to get the metagenome profiling of the world. So it's a large group of people from different countries, different cities. And then when the COVID-19 pandemic started, we came together and we realized there are problems with the PCR-based methods, and especially with the sample taking, and especially with mutations that are occurring in the SARS-CoV-2 virus. So we have decided to work on a diagnostic method based on LAMP technologies, and we developed as a company, as a group as well, Sezerman Lab, a LAMP-based kit, and these are really fast, so they are used for surveillance screening of individuals. But the way we propose is LAMP-based methods has problems with the false positives. So to tackle with those issues, we came up with several solutions and optimized our procedure and optimized our primers so that we don't get that many false positives. As a result, we built a diagnostic kit, 2 of them, one colorimetric kit and the other one is fluorescence kit for diagnostics of COVID-19. And it's frequently used in Turkey right now for surveillance. It's not recognized for diagnostics for sure, because WHO and also our health ministry considers only the PCR-based method as the true diagnostics method. But for surveillance, it's very much in demand. And we are currently surveying more than 1,000 individuals per day in several factories and schools and residences. And it's very fast, and its false negative rate is 0. It doesn't give false negative at all. And false positive rate, depending on the individual's saliva, we are testing from saliva, it's up to 15% false positive. But for surveillance activities, we are giving a more range to be tested with PCR, validated for PCR. So for surveillance activities, it's going up to 20% false positive rate. And what we are proposing is screening the wastewater to the companies, factories, where they have 30,000 employees. We are screening the wastewater for early detection of COVID-19. So we do regular sampling of wastewater from the factory, and we sequence them. And we get the COVID-19 DNA from the sequencing. Then we tell the company to screen the individuals for positive cases. And actually, we had very nice case in one textile company close to the border with Bulgaria. They were tested negative for 2 weeks in a row, and then all of a sudden the sewage sample tested positive. And that we notified the company, and they told us that they got 30 new employees, and they weren't tested for COVID-19. And we asked to test them using our LAMP system, and we found 1 positive out of those 30. And up to that point, the sewage samples always tested negative for the presence of SARS-CoV-2. So we ask people, we give this as a model for many big companies, because surveillance of all the employees takes a very long time, and it's very costly. That's why I think surveillance based on the COVID-19 presence in the sewage system and is a good way to screen thousands of individuals. And we also propose as a consortium, Meta-Sub consortium, we have a project called MetaSU, and we are proposing this to the municipalities to screen the regions, local regions, take samples from the local sewage system, find out the abundance of the COVID-19 SARS-CoV-2, and if you have high abundance in certain areas, use that information to develop your isolation policies. So, and we have ongoing projects in MetaSU doing this kind of activities, constantly screening the sewage system of different regions, and then reporting back to the municipalities to help them with their isolation policies. So I think that's enough for now, and I can contribute again later.
Thank you very much, Professor Sezerman, for your contribution and interesting strategy in controlling the spread of the disease. I will now hand over to Professor Peter Ianakiev, who will tell us about his technology and his company's activity in precision medicine. Peter?
Thank you very much, Nico. So Hera Biosciences, as the COVID-19 happens and progressed, focused on identifying different modalities what we can test. So what we wanted to do is to develop a test that is less cumbersome in terms of how we take the test. And to my experience and knowledge, the isolation of RNA in these tests is the weakest link. So we focused on direct kind of detection. So those efforts are still ongoing. We have ability to conduct this PCR test from different samples and sample places. As Professor Osman alluded, we can test wastewater, we can test saliva, we can test other places. The direct to reaction is what Hera Biosciences is trying to investigate. But in terms of what else it can be done, I think what it's most cumbersome for companies here in the United States initially was the regulatory burden. So to start testing, initially you have to go through a very, very robust, approval process, and even now, this kind of stops or puts a little bit of a break to the innovation. So I think in countries that have more flexible regulatory environment, things can go much faster. And in that respect, I think Bulgaria and Turkey probably are much more flexible in regulatory aspects of developing something new and testing new ideas than companies, say, in the United States. And this is a big advantage to those countries, albeit these countries are small and the resources are scarce, but that also drives the innovation in these countries. So I'm kind of very excited to be able to communicate with several countries in developing their tests and giving them advice on how to pursue their testing strategies, and even helping them with some reagents. So this is basically what Hera Biosciences is doing with COVID. With personalized medicine, we are trying to look into more of a evidence-based treatments. So treatment that are based on the outcomes. So this is a large undertaking that is still underway. But again, I think countries as small as Bulgaria have a chance to develop this kind of databases, which are very, very important, and to linked the missing link that it's there is the outcome and the treatment between the diagnostics. So we have developed many personalized tests. I mean, we know, especially in the cancer genomics, we know certain mutations are prone to be treated with certain drugs, and they have better results. However, what is still missing is the real outcome of these treatments. We know that these drugs are approved, we know that they work, but in the general population, we still don't know what is the real benefit. So that's where Hera Biosciences is also placing our efforts. One thing that concerns me about COVID-19 is that people have focused on the COVID-19 too much, and people have stopped going to regular checkups for their current problems, and they start avoiding hospitals, and that comorbidity, that mortality that will happen down the road for people who skip their cancer screening, their mammography or their colon cancer screening, it will be as significant probably as much as the COVID-19 itself. So we have to focus our efforts to educate people that facilities are safe, and as Professor Osman alluded, that we can do waste testing to make sure that there is no COVID-19 lurking about in these facilities. We can do fast diagnostic test. Right now, there's a company here in Boston that is developing a test based on CRISPR technology. Company is called Hera Biosciences. This company promises to make 1 hour test, and it's already in the realm of really testing patients. So it's really exciting to have these quick diagnostics tools in our hands, so we can help the people be more open and go to their regular physical checkups.
Thank you very much, Professor Ianakiev. I personally share a lot about what you said just now on too much focus on COVID-19, which is, of course, is very, very important and has significant repercussions worldwide. But at the same time, so many other patients who have neglected their care for chronic diseases, which unfortunately usually COVID-19 makes people with comorbidity suffer and die from the disease through neglecting their care just because they're scared. So we've just heard a nice overview in Singapore, over here in Europe with Turkey, Bulgaria, even the US, Boston, that testing and innovation has to look at a 360 degrees phenomenon, whereby we have to be able to have open genetic testing to better detect COVID-19 patients. We heard this from Professor Lezhava, how to scale up from 1,000 tests to 10,000 tests with standards that are satisfactory for diagnostics. We've heard from Professor Sezerman for rapid testing for environment screening, whether it's in the sewage of companies or towns or cities, to know how the pandemics evolve through a community of people, and to prevent overwhelming of the clinical system, which has been the main problem worldwide, particularly in the US and somewhat in Southern Europe. And finally, from Professor Ianakiev, we've heard how to optimize detection of COVID, and at the same time focus also on precision and personalized medicine to help people who still suffer from the chronic disease we're all very familiar with. I will invite people to ask questions through the chat mode, and the first one is to Professor Sezerman. In the context of your approach, Ugur, for wastewater testing, how often do you collect the samples, and do you pull all the samples at the end of the day before sequencing for a given area? This is one question from participants.
Okay, we collect 2 samples at a time, and depending on the schedule of the factory, if they work with 3 shifts, we collect 3 samples from each shift, at the beginning of the shift, in the middle, and at the end of the shift, and 2 samples at a time. And we pull the samples from the same shift. So 2 samples that we collected in the morning, we pull them at noon, we pull them in the afternoon, we pull them. And we also pull the samples from the same shift to see whether there are some differences. There are some minor differences. So if you are cost aware, then you can pull the samples from the same shift to see whether there is anyone positive in the same shift. But if you want to give more information to the company, maybe there were some people visiting and some people started their shift later, and so you can narrow down the people that will be surveyed, that will be diagnosed with the diagnostic kits later on. Otherwise, you have to screen everyone in that shift. So depending on how much they could spare for such screening event, we either pull all the samples from the same shift, or we pull the samples only that we collected together.
May I add to that question? First to you, Professor Sezerman, then I'll ask a question to Professor Lezhava and Ianakiev. In terms of this environmental testing, I know in France, particularly in Paris, there's an ongoing study that we hear about in the main news over here. Have you been able, with this testing, to help the health authorities to prevent this overwhelming effect that we have noticed in many hospital settings? Or is it still being used as a proof of concept methodology for the short future?
Currently, we are in contact with municipalities and health authorities. We started a pilot study in a small part of Istanbul to show that this can be used for isolation policies. But our consortium, MetaSU, is doing this all over the world right now, and they are working in close proximity with New York municipality, and they do show the benefits of such screening of wastewater in isolation policies and identifying hotspots, risky areas. Here in Turkey, we are applying it to factories, especially factories with many shifts and thousands of employees, which cannot afford to screen everyone at the same time. Otherwise, they have to stop production. So for those companies, we have 3 companies right now. We are constantly surveilling, and we show the benefits that it was negative up to a certain point, and they employed new people, and it became positive. And then they started to tell everyone that this is the best way to screen and stay healthy, because you cannot do the diagnostic testing every day. So without touching people, without disrupting the work, the best way to screen any place is through the sewage system. So we do have some cases that we are currently monitoring right now in Turkey, some factories.
Okay, thank you very much. Professor Lezhava, I wanted to ask you about the situation in Singapore and Asia. You've commented earlier on the challenge to go from 1,000 a day to 10,000 tests a day. Have you observed over in Singapore that this led to some delay in diagnosing sufficient proportions of the population?
I think you're on.
Maybe yes. Did you hear my question?
Yeah, I heard the question. Can you hear me?
Yes, it's fine.
Yes. So, what I was not clear, maybe that it is our lab wants to aim, and we are going for 10,000 tests a day. So this is doable because we are introducing automation. Without that, it is not possible. So we are introducing especially to dispense those samples and then extraction automated and so on. So this is something we are actively doing right now. On the same time, what about Singapore? I think this is very interesting concept. The proposal my colleague and proves that it is quite efficient to take waste and screen and sequencing. I think it obviously has a number of advantages. It's easy to collect and it's painless. Let's say you don't kind of stick this swab to patient all the time and so on, which is absolutely, I really like that approach. In Singapore case, we want to screen, we want to monitor regularly as many patients, as many, it's not patients, and as many population-wide screening we want to do. And one approach is to do to introduce in one UTM tube or 5 swabs, let's say. So we want to that we are increasing the screening the factor and also reducing the cost per patient. So this is something that we are aiming, and it is ongoing right now in Singapore. And of course, we need to pay attention on various things like 5 swabs in one UTM tube is more inhibition, and also it is less if there is one positive sample. Of course, it is we need to have a quite sensitive assay to detect one in 5, and especially when titer is low or virus titer is low. So I think those challenges are there, but I think we and the government are moving to that direction right now. So we want to screen population-wise, we want to go the regular screening. And we want to also do as less invasive possible, less painful as possible. So we are considering a number of different samples, nasal and also at the same time oral swab and so on. So these processes are ongoing, but every single change we will need to introduce additional validation to make it sustainable for clinic. Thank you.
Thank you. Professor Ianakiev, you mentioned that certain countries where the regulatory pressure maybe is less significant may have a competitive advantage, so to speak, to validate and develop new tests. Is it linked to what we've just heard from Professor Lezhava about non-invasive method to collect the specimen from patients, and or genetic screening technologies that are through this terrific period we're living in?
I think it's a little bit of both. I think finding the right sample will also facilitates better sensitivity of the assay. I think what currently the many countries experience is trouble isolating the RNA from the virus because of the small amount of RNA in these samples. And what I'm advocating with Hera Biosciences is to use direct methods, just to use virus enrichment beforehand from the sample, and then use that enriched sample directly into the PCR reaction. However, I'm also excited about the environmental testing, because this environmental testing is an early indicator. It happens before you get a significant amount of patients into the hospital. So there will be a shift, and this shift is probably around 2-3 weeks from where you can find the virus in the sewer by the time these people go to the hospital. And by the way, by the time people go to the hospital already, they may be carrying not so much of the virus. So the viremia, the large titer of the virus is early on. So it's getting hard to test just patients who are already sick. It's much more easier to do a large scale testing of environmental samples. So in that respect, I agree with Professor Sezerman that this is one exciting way to approach the problem. I'm also excited about new technologies in terms of next generation sequencing, which I have been using for many years right now. My company is devoted to NGS. And the only issue with that is how we can multiplex multiple samples. We are talking about samples in the realm of thousands, because the throughput of next generation sequencing is such that we can screen 10,000 samples in a single run. We just need to find a way to multiplex those samples and to produce those samples in a reproducible way. So that's where the automation comes into play. But exciting times. I think we are very close to introducing this here in America, these new technologies, and the infectivity rate, that positivity rate of these samples that we are testing is going down. So even though the numbers of positive tests in America are going up, this is largely due to more availability of testing.
I have a question for you, Peter, from one of the attendees. Are there any talks about letting kids back to school in the US? And is there an established strategy to control the infection in this scenario?
Yes, so I can tell from my own experience, my kid is going to school right now. He's 7-year-old. The school have implemented strict distancing policies. The kids have face masks and they stay 6 feet apart. They have like stations in their study desks that are kind of encased in plastic, like transparent, but we feel comfortable. We don't feel that this will be a big issue. My son has been participating in social activities with other kids that, of course, are again with social distancing, and they don't commingle too close. But in America, what happens here in Massachusetts, each school adopted their own kind of strategy. So some schools have 3 different layers. Kids who are, 100% going to school, kids who are hybrid, 3 days on, 2 days off, or vice versa, and kids who are 100% virtual. My older son is 100% virtual. He is a high schooler, and that works well for him. But for little kids, virtual education is almost impossible.
Yeah, sure. And what is the policy? And I will ask the same question to all panelists in terms of contact cases. Let's imagine in a school there are 1 or 2 kids from a class that are confirmed positive. Do they put under quarantine the entire class, or they just push towards rapid testing of the other classmates?
Yeah, we had cases in our high school where there were positivities, and immediately the government dispatched the testing facility to collect samples. Of course, everything is voluntarily. So not only from people who are in contact with these families that have kids that tested positive, but also anybody who wishes to be tested can go and it's like a drive-through. You park your car, somebody comes and take your test, and you get your results next day. So
okay. From a personal experience with my oldest son, we had to wait as long as 6 days to get the results. So of course he had to stay at home during that time.
Yeah,
it was negative in the end.
Yeah. So self-quarantine is
discrepancies between countries. What is the policy in Singapore, Professor Lezhava, in terms of testing and putting contact cases in quarantine?
I don't comment about schools because my kids are grown already. So, but generally, I would say that both contacts, identification of contacts, this is very important. And then, of course, a screening as well. Of course, the screening. I can add on that every single person whoever goes out and they have to register whenever they go into shops or some shopping malls, shops, some supermarkets. We all work as well. We all register by scanning of our mobile phones, and also so basically we can be monitored about our contacts, where did we go. Every day we are monitored basically. So this is then it gets later, it gets easier to identify contacts and so on. So this is something that government pays very huge attention, and we are even at work. Let's say if we forget to scan in our presence, we might get some penalties and checking and so on. I think those measures are not very pleasant, but quite important, and to monitor and to kind of isolate people when it is necessary. Yeah.
Okay, thank you very much. Professor Sezerman, maybe a comment on the situation in Turkey?
Here what they do is schools are open, but only some levels are attending one day, and the other levels, like grade 1 attends on Monday and grade 2 attends on Tuesday, kind of activities, and most of them are online education, so they are not exposed to threat that much. But if they identify someone, they do the screening for the people that are in contact with them, and they do the screening for 3-4 days, and if they are all negative, then they are okay to attend the school again. But to minimize the risks, they don't have the schools open every day. They lowered it to 1 day at a week. People attend classes, students attend classes. But what we do, I think the LAMP-based diagnostic kits provide a good way to screen individuals. I think it's a perfect application, because in a fast way, you can get the negative people. And screening the negative, if you should trust your negative. When you say negative, and if it's 100% correct, then those people are free to go. And this kind of screening can be done using LAMP-based diagnostic kits. So, especially for the operations here, there was a backlog. The people were waiting to be operated because they needed to have the tests done. And they were waiting 6-7 days to get the tests done with the PCR-based systems. We stepped in, and now we are screening many patients. And if it is negative, it's free to go to operation. If it is positive, then it has to be validated with PCR-based systems. So I think this way it offers a good chance to screen thousands of individuals, and you can trust the negative value that's coming out of the lab test.
Wow, so like a 2-stage screening.
Yes.
Mm-hmm. I understand. The next question is addressed to you by one of the participants. Do you expect a shift to saliva as a primary sample material? And what do you think are the risks associated with adopting this sample type? In fact, we will ask you first, Professor Sezerman, and then Professor Lezhava and Professor Ianakiev.
I think saliva is the correct medium for sample collection. Swabs, unfortunately, it's painful to get samples correctly with swabs. People react to it automatically. We say that if you are taking a nasal swab, if you don't cry, that means they didn't sample it good enough. You have to get your tears coming down to touch the correct space to get the sample. And so it's very difficult. People react to it automatically, and they don't get the good sample, and most of the false negatives are because of the sampling problems. So in that sense, saliva is a good option. And what we do in our protocol, we make people cough first with their mouth closed to get the things that are in the throat into the mouth. Then we get the saliva samples. Of course, it's very difficult to work from saliva samples because it messes up with your reactions. It has lots of things inside. We had lots of problems developing our protocol. We had to deal with so many issues, like if people are taking certain types of drugs, their saliva is acidic, too acidic, and it interferes with our reactions in the LAMP-based technology.
Okay.
And so we had to take into account all these things to get the good samples. But we have now already developed protocols in place, and we do see differences between the saliva samples and the swab samples. The things that we can diagnose early on, they couldn't be diagnosed with the swab samples. We did several studies where we took the swab and the saliva from the same individuals, and we could diagnose the person as positive from the saliva and negative from the swab sample. So we do see advantages of the saliva.
Okay, thank you. Interesting. Professor Lezhava, you said from a end user perspective in the Institute of Genomics in Singapore that you are interested in alternative primary material for diagnostics. Would you like to comment on that, as saliva, or maybe you mentioned oral swabs earlier?
Yes. So already a number of companies are coming up with saliva-based testing, and so some of them are getting to, of course, the most of them are coming up with a purification method and then running PCR. But also, interestingly, there are some direct methods as well. However, for direct PCR or on the earth thermal amplification-based tests, they are less less convenient compared to nasal pharyngeal sample, because as already it was mentioned by my colleague that there are some acidic and some inhibitors inside and so on. So there are some companies are coming up with direct method, but they have some treatment compared to nasal swab samples. So yeah, but it's obviously there is a advantage, and it's getting more and more popular, I would say. Yeah.
Okay, thank you very much. Professor Ianakiev, do you have a comment on that? Peter?
Am I on mute?
Yeah, we can hear you now. Yeah.
Okay. I think I'm more inclined to the tiered approach. The one that's convenient will be a screening method to screen many samples, and then samples that show positivity to be confirmed with another orthogonal method, for example. So we definitely need something that works fast and is quick to do these mass screenings and get results within 5 minutes or an hour, if you wish. And then if some of those samples show positivity, we need to confirm that. So having saliva test, I think it will be very important. The issues with contaminants can be overcome with some enrichment and purification methods that can mitigate those issues. But I think as ease of implementation, the saliva and the oral swabs are probably the best place to look for advances.
Okay, thank you very much. We are coming to an end of this atelier, so maybe a little bit of perspective now in terms of evolution of this pandemic. It's diagnostics and treatment. I will start with Professor Lezhava. How do you see this international global situation evolve over the next few months? You're on mute, Sandro. Okay. Still on mute. Okay.
Okay, right. So
yeah, we can hear you. Thank you.
Unfortunately, there are not so great news about the numbers are still there, and unfortunately, there are some cases, some countries they are increasing. This is a reality. Some countries are doing well, but again, I mean, the community now is basically when people are traveling, given their restrictions and bringing from one to another country disease and so on. Here, I think efficient screening is very important, which is so many countries are going there that airport screening, fast screening that it was mentioned, this will take, and also most importantly, sensitive screening, sensitivity should be there because another one big part of population, they are non-symptomatic, they don't have symptoms, but they are carrying still disease and they are spreading disease as well. So those things are under consideration, and this is one direction. Another thing is the treatment-wise, healthcare here is very important. So I can tell about Singapore that mortality is very low here. From about 60,000, we have only 20 plus tests, if I'm not mistaken. Yeah. So I think healthcare itself, identification, proper healthcare is very important in this case. Until we don't have any, still we don't have any ideal drug which will target particularly this infection and this virus. So, but vaccine is coming. So there are some hopes, and my biggest hope is that which we observed before during SARS, that virus is getting weaker, and hopefully this will not impact so much about one else. Yeah, that's all I can say. Thank you.
It's clear. I join you with that hope. Yes, for sure. Professor Sezerman, what's your take on the future of the virus in Turkey and worldwide? I know you have some interests, academic interest in vaccine design, for instance. How do you see this pandemic evolve?
The way I see it is because of the economical worries, they had to open the economies. And without declaring it, actually in the world, we have a kind of promoting herd immunity. Because we saw that we cannot handle the economic burden of shutting down the economies. So that's why, without stating it, they are protecting the vulnerable people over certain age and some vulnerable people with some comorbidities. They're protecting those, so there's no heavy load on the health system. But then they are letting others to mingle with each other or come in close to each other. So in a way, it's a slow herd immunity process that's going on. That's the way I see it in the world, and they're refusing to shutting down the economy. We saw that it worked, but the economic burden was too much. So I think it will go on like this, like we will see increasing numbers and some risky cases, rise in the deaths and so on. Some populations with better healthcare policies will have less deaths than the others. But I think it will go on like this. I don't trust too much about to the vaccine. Because the way the vaccines are working, and I see the candidates that are coming out, I don't think it will work for all the people. It will work for some part of the population, but it will not protect the rest. So I think we will learn to live with this, and the way it's going is I don't know exact numbers, but the death rates are getting lower and lower, so the virus is becoming less deadly. This burden on the system, in Turkey, it's basically an open economy. And the numbers went up to 1,700 a day right now, and we see only 50, 60 deaths per day.
Yes, so, it seems to be a global trend, and most people have comorbidities or are of a significant age.
Yes. So with the vaccine, yes, it will come, but by the time it comes, we will have the real impact on some people, especially the risky population.
Maybe so, behind us by then, yes.
The way I see is this screening policies are crucial, especially with the sewage system and isolation policies to minimize these risks and and I think these should be adopted globally, everywhere. So you identify risky areas where there are hotspots and isolate those areas to protect the rest. And it will not put too much burden on the economy. I think that this should be done globally, everywhere.
It's a very clever, smart approach indeed, yes.
Yes, and also I see the risk with PCR-based technologies. They give so much false negative. And the main reason I see is they want to speed up the process. They don't want to isolate the RNA, and they went into quick ways and skipped the RNA isolation step, which caused lots of problems with the accuracy, especially with the false negative rate is rising up because of that. Because from the RNA it works fine, but then it's too cumbersome, too costly, and they don't have enough trained personnel to take.
It takes too much time as well to get results, yes. Mm-hmm.
So, and that's why I think we should move towards faster and more reliable screening technologies as well.
Okay, thank you very much, Ugur, for your take on the future. We will let Professor Ianakiev conclude with 2 minutes. We're slightly over time, but Peter, we would like to hear your take on the future and the evolution of this pandemic.
Thank you very much. I'm not a virologist, and probably there are many people here. I see one in the audience, Professor Argirova, who is much more involved in virology than me. But as I see it, as coronaviruses have been with us for a long time. And to my knowledge, those coronaviruses that have been causing like a mild infection, there is no vaccine for them. So it will be very hard to come up with vaccine. But the future, I think, will be that this virus will kind of lose its ability to cause severe infections, or we will adapt our immune system. But vaccines, in my experience, probably will take a very long time to be tailored and be 100% effective, as Dr. Sezerman said. Herd immunity probably will be achieved at some point, but that will come at a cost. So the cost will be for us to endure these economy shutdowns, and that cost, we don't know how much it will influence the healthcare system itself. So I agree that we should be focusing our efforts to protect the vulnerable and old. Most deaths here in Massachusetts were located in the senior care facilities, people who are over 80. So these are vulnerable people which the healthcare system could not protect adequately. So that's where we should focus our efforts, and then the virus will play itself at some point. I don't know if it's going to be 2 years, 3 years, or 10, but as other coronaviruses evolved, they become part of our regular viruses that cause mild infection. Thank you very much.
Thank you, Peter, for your take on the future. I would like to thank all panelists, Professor Lezhava, Professor Ianakiev, Professor Sezerman, and I would like to thank the organizers of the Biotech Atelier for the great organization. And we would have loved to be all in Sofia to enjoy the company of each other. Unfortunately, it's not possible this year. So thank you for organizing it in this format. Thank you to the participants for listening to us. And I will see you in other Biotech Atelier later on. So thank you very much, and be safe.
Thank you, Dr. Forraz.
Thank you. Bye-bye.
Thank you. Stay safe.